I'm glad you can hear me. Thanks, Michelle, for the introduction. I've been teaching about cancer for the last, I mean, you mentioned 30 years. It's about 30 years since I've been that I've been teaching about cancer, and what an amazing 30 years, because I've gone from the place where we knew little bits about cancer, but not an awful lot. This is going back into the sort of early 80s. Coming to a situation now where we know so much about cancer, and we know so much more about how it works, what makes it tick, and what we can do about it. So I'm going to share some of that experience with you throughout the next hour or so on this presentation. I'm very happy for you, by the way, to post questions in the chat as we go along if you want to, and I'll try answer them as we go through. If you prefer to wait until the end, and we can sort of answer some of those questions there as well. But I've got a feeling that throughout this presentation, I'll have some questions that I might want to ask you, so then you can just type the answers in as we go through. So let's get cracking then, and think about what's going on in terms of cancer, and introduce you to quite a lot of the terminology as we go through. So Michelle's already alluded to the fact that it's on the increase. It's been on the increase for many, many years. So it raises quite a large medical issue in terms of how we deal with this disease. And as you can see by the graph here, it's an older person's disease, is cancer. Yes, we do get cancer in younger persons, it's that sort of middle age range. But generally speaking, the vast majority of people who come to our door will be over the age of 55, 60 years of age, with most of them being 70, 80 years of age. That causes a bit of an issue because this particular group of people gives a bit of a challenge, in the sense that they don't just come through the door with cancer. They come through the door with heart disease, with diabetes, with dementia, all these other things that make then treating these people and managing this person with cancer more of a challenge. There are certain chemotherapy drugs, for example, that we can't give if a person has heart problems, or it would be very difficult for us to give. We'd have to be very, very careful, because some of the drugs that we use are cardiac toxic. So that would be difficult to use that in patients who have got heart disease, for example. Some of the drugs that we use are toxic to the lungs. So that's very difficult to use if we have people with lung disease. So that's not to say that young people don't get cancer. It's just it's more common in that older age range. There's several reasons for that, by the way, and we've already alluded to that already. We are an aging population. We have more and more people living into those age brackets where this disease is more prevalent, and therefore the rates of cancer are going up as we live longer, okay? Part of the reason we're living longer is because we're doing better with other diseases that tended to, unfortunately, kill us before we reach the age of 40, 50 years of age. Now people live into those age brackets. The figures are that 1 in 2 of us will get cancer throughout our lifetime. Now, that's a lot, but 3 in 4 of us will survive that cancer. Yeah. So we have an issue now, not in terms of how we try to work to eradicate cancer or cure cancer. That's difficult. Our idea now is how we can, one, reduce the risk of developing the cancer, but also then if we have a person with cancer, how we manage them throughout either their time alive, or whilst they survive their cancer and their treatment, how we manage them through that and help to deal with them going forward, because there's going to be an awful lot of people, there already are, that live with their cancer for many, 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 many years, okay? We're not really in a position at the moment where we can cure our way out of this situation. There's several reasons for that, and I'll allude to that as we go through the presentation. But more of the information that comes out of places like government, like Cancer Research UK, for example, It's moved away over the last 20 years from finding a cure for cancer. We're still trying to do that, don't get me wrong, but more of the stuff that comes out of these places is to do with how we can reduce our risk, leading a better health style, healthy lifestyle, being able to not imbibe in certain substances that may then increase our risk of developing sort of cancer. But the important thing is, of course, to prevent or to reduce the risk of getting cancer in this age range here, we need to start the good habits here in this younger age range. Because cancer is a progressive disease. It doesn't just happen. There's lots of changes that occur to get us into that situation. So let's have a look at some of the things that are going on. This graph here represents, or this chart here represents the changes in the numbers of cancers coming through our door in that 10-year period. So that decade period between 2005 and 2015-ish. So what we have is male and female here, and we've got a line going down the middle of each of the bar charts, which represents no percentage change. So anything up towards the right-hand side of the chart, as you look at it, we see a percentage increase, and anything to the left-hand side, a percentage decrease. Now, you can pretty much see, without even reading all the terms, that pretty much everything's on the increase, bar a few exceptions. So I'm going to point out a couple for you, and let's just sort of start to understand what's going on here. Lung cancer. In that 10-year period between in this time frame, we've had a percentage decrease in lung cancer in males, but a percentage increase in females. Now here's the first interaction. Let's see if we can get you typing in. Why is that? What's the reason for this increase, particularly in females? Can anybody offer any ideas? Doesn't matter if you can't, but let's just see if you can. What do we think might be causing this change? We're seeing the numbers of lung cancers in men decrease, the numbers of lung cancers in women increase. See if you can put in a chat. What do you think is going on there? Any ideas? Nikki, it's not passive smoking, although that is important. And there's a whole issue around passive smoking and secondhand smoke, but it's smoking in general. What we've seen since the sort of late 80s, early 90s is the men started to give up smoking as a population. Yeah. So, and there's a very close correlation between smoking and lung cancer. That's how it works. So as men started to give up smoking, so their rates of lung cancer decreased. In that same time frame, what we've seen is more women taking up smoking. No surprises then, the more women that take up smoking, so the rates of lung cancer increase. If you go back to the sort of mid-70s, for every one woman with lung cancer, there were 4 men. It was a 4-to-1 ratio. Now it's almost 1-to-1. It's about 1.2 to 1. We've almost got the same, of the 47 or so thousand people with lung cancer diagnosed each year in the UK, 51% will be men and 49% will be women. It's almost 1-to-1. It's all down to smoking. Here's another one, melanoma skin cancer, the one that we're all sort of afraid of, this idea of this aggressive type of skin cancer, which is actually on the increase, massive increase in both men and women, okay? Do we know what the risk factors are for melanoma skin cancer or skin cancer in general? Does anybody know what the risk factors are? And I'll also highlight the fact that these percentage increases, you've got to be very careful when talking about percentage increases because they don't easily equate to actual numbers. They do eventually. But normally when you get large percentage increases like this, it's because the numbers are still relatively small. So for example, if there were 2 malignant melanomas here and I got another 1, it would be a 50% increase, but it's still only 3. Yeah. So the numbers of malignant melanoma are not huge, but what's huge is the percentage increase. And when we get percentage increases like this, if we don't nip it in the bud quickly, then we do end up with huge numbers. The risk factors against skin cancer in general, and particularly malignant melanoma, is exposure to sunlight. In particular, Barbara, what is it in the sunlight which causes the problem? Do we know? What is it in sunlight that actually causes the problem? What is the thing in the sunlight which is causing the damage? Do we know what that is? It's UV radiation. But here's another question to you. Where else do we get UV radiation? Any ideas? Where else do we get UV radiation? In sunbeds, not our phones, but in sunbeds. Yeah, in sunbeds. The power of modern day sunbeds, they're very powerful. The level of UV radiation exposure is high, generally speaking, on parts of the body that aren't very much used to being exposed to the harsh levels of UV radiation as they are. So we've got to be very careful about using sunbeds, particularly in young people. In fact, I think it's against the law now for people under the 18 to be able to use them, although they do. Okay, so we know that these risk factors. Let's have a look at another one. Head and neck cancers on the increase in both men and women. Now, traditionally, the risk factors for head and neck cancer have been smoking and drinking. And especially when they smoke and drink together, they have a sort of like a synergistic effect. It's even worse. There's another risk factor there that you may or may not be aware of, and that's a human papillomavirus, which we tend to associate things with like cervical cancer and things like this. But we're actually seeing it crop up in other areas of the body that might be associated with intimate sexual contact and things like this. So that virus is being transmitted to these other parts of the body as well. Let's have a look at another one. By the way, if there's anything on this graph that is of interest to you or jumps out of you and you want to find out a little bit more information, a snippet of information, just type it in and I'll see if I can answer the question. Here's a good one. Ovarian cancer has been on the decrease since the sort of late 90s, really, which is a good thing because prior to that, it's been on the increase. Now, we actually think that we're seeing this downturn in ovarian cancer as a result of the contraceptive pill that women maybe started taking in the sort of late 70s, early 80s. That type of contraceptive pill or oral contraceptive pill has given them protection from ovarian cancer when they've hit 50, 60 years of age. So that's been a sort of a positive sort of side effect, if you like, to taking that, which has been very good. Anything else on that graph of interest to anybody that you can see? Anything that you want to hear about? I'll point out one I wasn't going to do, but everybody sort of asked about thyroid cancer. That's on a massive increase, look, 68, 69%. But that's again usually because the numbers are really quite small and therefore you get large percentage increases. Breast cancer is we're always going to get a lot of breast cancers. Breast cancer is very much linked into well, various things really, but a lot of those we can link down to lifestyle habits of the sort of modern woman within societies like ourselves, really. So we know there's a link between breast cancer and obesity, breast cancer and alcohol, breast cancer and well, age. We know about age and these sorts of things, and also exposure to estrogens throughout a woman's lifetime as well. So all these things play a role. So the decreasing stomach cancer has been a good one, really, in the sense that we know what one of the principal risk factors to stomach cancer is, and it's the the name's just escaping now. It's the bacterial infection that we can get in the stomach. Who can help me out here? What's it called? Helicobacter pylori, H. pylori, you might have heard people talk about that. So H. pylori is a bacterial infection that some people, Helicobacter pylori, that's it. Some people have that in the stomach and they live with it, but other people it gives things like ulcers, stomach ulcers and things. So what tends to happen is we pick people up with a stomach ulcer, we find the H. pylori, we get rid of it, and basically we prevent them from going on to develop stomach cancer. That's how it works. So yes, that's been a good one over the last sort of 20, 30 years, is that we've done really well. So I'll move on to that from this graph to talk about some more things about cancer. So Michelle's already alluded to the fact that this is a very emotional word, but it's in the middle of your screen there. And before we fill the screen out, just type in, when you hear that word, when you see that word, when you read that word, what is it that pops into your mind? What's the word that what terms do you associate with cancer? Let's see how many we can get. Type as many as you can in. Let's see how we get. Death, fearfulness, disease, fear, death. Hair loss, yeah. So that's a side effect to either the cancer itself, maybe, or the treatment. Definitely life-defining. Pain, scared. There's some great stuff going on here. Yeah, absolutely. So let's fill this slide in with some of the stuff that, I mean, I ask this question a lot during my sessions, and I get, depending on who's on the session, influences really what the types of comments that come back. And some of them will be more scientific, and others will be sort of more emotional. And you notice what I got on there also is death. So the thing about death is an illness, yeah, and damage, universal, all these things. Fear is another good one. Now, what we've got to understand about cancer is that if we go back 20, 30 or so, 40 years, cancer was very much that sword of Damocles hanging over our head, wasn't it? It was very much was considered a death sentence, the big C, all this sort of terminology. It's not so much like that nowadays, to be honest. We still have that fear, but that fear and this idea of death associated with cancer is very much a historical thing that seems to have stayed with us. There are certain types of cancers that we get now that are eminently curable. Kids with acute lymphoblastic leukemia, the vast majority of these will survive. Kids with nephroblastoma or Wilms tumor, kidney cancer, they will survive. Hodgkin lymphoma, it's got one of the lowest mortality rates in Europe. We do really, really well with Hodgkin lymphoma. 85% of women with breast cancer will survive, either get rid of their breast cancer or survive with it for a long, long time. There are certain types of cervical cancer. We don't really have too much of a problem with it because we have a great screening program. And now, of course, we have the vaccination against the HPV, human papillomavirus as well. So there's certain types of cancer where actually we do really, really well, or we're able to manage the persons through these diseases. There are certain types of cancer where we still struggle with, pancreatic cancer, lung cancer, for example, certain brain tumors. But actually, we do so much better with cancer than we have done ever. We have better treatments. We're able to manage people through the disease much better than what we ever have done. So we need to get away from this idea, I believe, that cancer is a death sentence, because it strikes too much fear. And and that is a barrier sometimes to people going to doctors and seeking medical advice, because they are scared of what the ramifications will be. Don't get me wrong. In many cases, it is very much life-defining, and it can be life-shortening, and it can cause a lot of problems. And the treatments that we give can cause a lot of problems. But the overarching thing here is, if we can pick up these diseases early, we have a much better chance of dealing with it successfully. So a lot of the information that we get, some of the stuff I'm going to talk to you about today, is to make sure we get people through the doors early so that we can get people to seek advice, and therefore we can deal with these things in a much more timely manner, if you like. From a scientific point of view, we're going to just touch upon some of these other things as well, so that you can begin to understand what it is about how cancer develops and what it is that that cancer does, which causes us such a problem, really. And then we'll sort of spend a bit of time towards the end looking about how we can deal with this as well, and some of the treatments that we have that we can use, really. So the challenge that we have with cancer quite often is that we have one word for it: cancer. So we think it's one disease. Actually, we have, well, it's quoted that we have over 200 different types of cancers. Now, in reality, there's more than that, because each type of cancer has their own subdivisions. But the reason why that number 200 comes from, where it comes from, by the way, is the fact that we have roughly 200 different types of cells and tissues in our body. And in theory, any one of these cells can become a cancer. So therefore, you get your 200 different types. In reality, it's lots of different types of cancers. It's not one disease, but it has certain common elements to it, which is why we group it together under that umbrella. So we know certain things, and let's unpack this. We know that it manifests itself as a neoplasm. And by neoplasm, we mean a new growth. You might call it a tumor, yeah? Tumor just means swelling, really. Neoplasm means a new growth. Neo meaning new, plasm meaning growth, a new growth. Now, how do we get this new growth? Well, it comes from what we call uncontrolled proliferation of normal body cells. Now, let's just unpack that statement. Proliferation means we produce a lot of cells, but that can be normal, okay? For example, if I cut myself here, I basically make a gap between the two edges of the skin. So I have to proliferate, I have to produce more cells in order to bridge the gap. But once that gap has been bridged, the proliferation stops. So it is controlled. Here, it's uncontrolled. These cells don't get the stop message. They continue to grow when they shouldn't do. Grow and divide. So we get too many cells being produced, which then group together to form a clump of cells that we call a neoplasm or a tumor. Yeah. The other thing to note here, these are your cells. This isn't something that's come from outside. These are your cells that turn rogue, if you like. Okay. So what switches these cells onto this uncontrolled cell division and growth, proliferation? Well, it's some form of change or mutation within the genes of the cell itself. Now, when we talk about genes, we say, oh, that's what gives us the color of our hair, the color of our skin, this sort of thing. It does. They do. But individual cells have genes in them which tell the cell what to do, when to do something, why to do something, and how to do something. And in particular, we have genes which switch the cell on to division and growth, and genes which switch it off. And normally that's in balance. Now think of a gene as like a recipe. It's an instruction to do something, produce something, a protein, or do something. Think of a recipe for your favorite, I don't know, cake, whatever. If you follow that recipe, you get your cake. That's how it works. If we change something in that recipe, unbeknownst to you, and then you follow it, so you put 3 eggs in instead of 2 eggs, you follow the recipe, you put the 3 eggs in, it's still a cake, but it's a little bit different. And then we say, oh, you put more sugar in. and you follow the recipe, put your 3 eggs in, more sugar, and it's just a little bit different again. And the more changes we make to that recipe, the further away from a normal cake we get. And that's exactly what happens to these genes. We do little bits of changes here, a little bit of changes there, till eventually the message that this gene is giving to the cell changes. And what tends to happen then, we end up turning the messages on, telling the cell to grow and divide, and turning these genes off, which is telling the cell to stop. So we create an imbalance. We get too many on messages, which basically switches the cell on to this uncontrolled proliferation, which means we produce too many cells and we get a tumor or a neoplasm. Now, what causes these changes, this mutation? Well, it's damage to the cell, damage to the DNA, damage to the genes. And that damage can come in many forms. It can be caused through random events that happens as a cell replicates. So when a cell divides, it has to copy over all the DNA. DNA is massively long and complex. It's a bit like me saying to you, there you go, there's all the Harry Potter books. Copy them out word for word all day long. That's all you're going to do. Just doing that simple process of copying them out, you will make mistakes. You might misspell a word, you might put a full stop in the wrong place or miss a comma out, but you will make mistakes. The DNA, when it's being copied, we do it with mistakes. Now, more often than not, those mistakes can be rectified, they're picked up on and dealt with. Sometimes they're not. And sometimes then those mistakes get exacerbated and get worse and worse and worse. There are certain types of cancer where we've got no rhyme or reason why people get them. They just do. Brain tumors, for example, we don't really know why people get brain tumors. They just do. And it's probably just some sort of random error that's happened as these cells have started to replicate. There's stuff in the general environment that we don't have an awful lot of control over, but which are still causing us damage. Radon gas that comes up through the ground in certain areas of the UK in particular, where there's lots of sort of volcanic rock like Cornwall and Devon and places like that, South Wales. There's stuff in the general, car exhaust fumes, which contain carcinogens. There's stuff in the general environment that causes damage. Now, we expect government and legislation to help us with that. We don't really have too much personal control over that. But our self-exposure to carcinogens, we do have control over. What are the sort of things that will fall into this third bullet point? Any ideas? Type in some stuff. What are the things that we do to ourselves which might increase our risk of causing this damage and therefore increasing our risk of getting these diseases? We've mentioned some before, but let's see if we can get another list. Smoking, of course, Christina, absolutely. Yeah, smoking. What are some of the others? Michelle mentioned quite a few actually early on. Unhealthy eating leading to obesity. We know there's a link between diet and certain types of cancers. Drinking alcohol is what we mean there, I presume. It's a lack of movement, again, linked into sort of lifestyle, isn't it? And obesity and that. We know there's a link between obesity and cancer, certain types of cancers. I'll be honest with you, we don't really know what the actual link is. We just, in most cases, there's sort of hypotheses, but we know that people who are obese tend to get more of certain types of cancers. We don't know what it is about being obese that actually does that. It might be the estrogen deposits that we store in our fatty deposits. It might be the stress hormones that we release because we've got more cells that we have to deal with. Could be all these things or a combination. Pollution, we've already mentioned the sort of thing. We know, yeah, we're going to be careful with certain things that we do find, not only in beauty products, but other products as well. For example, processed meats, the nitrates that are in the processed meats are the issue there. But But yeah, definitely, you guys will be more experienced in terms of beauty products than I do. But there are certain beauty products that we've got to be very, very mindful of in terms of what's in their composition. Yeah. So there's some of the things that we've already mentioned. One that we didn't pick up on, I mentioned it earlier, there are certain viruses that we know increase our risk. And this is an interesting one, asbestos. Anybody come across asbestos as a risk for certain types of cancers? It's a particular type of cancer called mesothelioma, which is sort of it's not a lung cancer, but it's associated with the pleura which line the lung. It's one of the few things that we actually know is a proper causal relationship. So people who are exposed to asbestos, people who get mesothelioma, have been exposed to asbestos. Yeah, that's a sort of cause and effect relationship. Whereas all the rest of it, they put us at risk, higher risk. By far and away, by the way, smoking is the biggest risk factor, and then followed probably by obesity and things like this. The reason why smoking is such a big risk factor, by the way, is because there isn't just one carcinogen in a cigarette. There are many, over 30 of individual carcinogens. And that's why somebody mentioned earlier passive smoking. That's why that's such an important issue. The smoke coming off the end of a cigarette, it's unfiltered. Normally when people smoke a cigarette, they smoke through a tab. It filters out some of the harsh chemicals. But some of the smoke coming off the end of the cigarette is unfiltered. It's actually full of these carcinogens that then other people are smoking. It's estimated, it's hard to quantify, but anywhere between 5 or 30% of lung cancers could be caused through secondhand smoke, passive smoking. Now, if it is anywhere near 30% of 47,000 people a year is a lot of people getting lung cancer through no fault of their own. Yeah. So, cancer is a progressive disease. It takes time to happen. It's a whole range of different diseases under one umbrella of cancer. But we can define it by certain characteristics that it has. We call these the hallmarks of cancer, and they are on this sort of graphic here. I'm not going to go through them in any detail whatsoever, but where this is important, it's a list basically of characteristics which define cancer as a disease. Now, the first list was only coined in, I think it was the year 2000 by Hanahan and Weinberg. Yeah, there you go. There's the reference there in this journal called Cell in the year 2000. That was the first time that we got this list. I've worked almost half of my professional life in cancer not having this list. We sort of knew bits of it, but now we had a list. We had a list of things, traits, characteristics which defined cancer. Now, why is this important? It's important because if we can work out how cancer works, what makes it tick, then we can devise strategies to work against this. So these now, all these things that cancer can do, they are becoming our targets for our treatments. And if we can target these and stop them from happening, maybe, just maybe, we can start to stop cancer in its tracks. So that's why this knowledge is important, these hallmarks, is because it allows us then to develop treatments which will directly interact against the cancer cell. And I'll tell you a little bit more about why that's important in a minute. But cancer is a progressive disease. It's lots of little bits of damage over a long period of time. We don't start smoking on Monday and get the lung cancer on Wednesday. It doesn't work like that. People start smoking when they're 14, 15 years of age, and unfortunately the lung cancer kicks in when they're 45, 50 years of age. That's how it works. So our challenge has always been getting people to do the right things earlier, an earlier age, The challenge we have, of course, is telling a 14-year-old what's going to happen to them when they're maybe 50 years of it. They're not interested. I certainly wasn't interested when I was that age. So what are some of the trends that we've already mentioned some of them, but let's just think about what's going on. One of the main trends around cancer, of course, is survivorship. Not only survivorship, but people who are older coming through our doors with this disease. They come through the door with comorbidity. They come through the door with other things wrong with them. We have more people surviving cancer and therefore needing more treatment for longer. Yeah. So all these things are causing a challenge going forward, and we need to be able to deal with that. And all that's going to happen is we're going to get more of these people are needing more resources for a longer period of time. And that's going to have pressures on the system, of course, going forward as well. We also know that we're starting to individualize more our cancer treatments. Sort of alluded to a little bit with this targeted approach. We're starting to, we're not just interested in the fact that this person's got a lung cancer. We want to look at the lung cancer to see if it has any genetic makeup that we can utilize, that we can almost pick it out as a weakness and therefore develop a treatment against that particular genetic subvariety of that lung cancer. So we're getting a much more personalized approach to our treatments, not completely personalized, but a much more personalized approach to our treatments, because we base it around those hallmarks for that individual cancer and the genetics of that cancer. Now, what that means is that we have lots of different combinations of drugs that we use, because we're using them based on what we know about that particular type of cancer. And what we're also seeing, we're seeing more drugs coming on the market than ever before. Lots of choice, and they're coming on quicker. The way we run clinical trials now has become much leaner. Clinical trials used to take 10, 15, 20 years before they yielded any useful information. Now we can do them in a much shorter time frame, which basically means we can get active drugs, for example, onto the market quicker. Now, there are still issues around that, particularly one of access and who can have them and things like this. And that a lot of that is linked into, again, the genetics of these particular types of cancers. But the big trend here is the fact that we're getting more people coming through our door with cancer who are of an older age range, who tend to come through the door with other things wrong with them. If you couple that also with the fact that I said that people are surviving their initial cancer, the challenge that gives us is that they may live into an age bracket where they might get a second type of cancer, which ordinarily they wouldn't have had. Yeah. So that said, then, what treatments are available to us? Well, we have many. I'm going to sort of pick up on a couple of them, but all the treatments are impacted upon all of these things around the outside. And they're all just as important as each other, really. We know certain treatments will be available more in certain places than other places. Technical stuff like staging and grading are important. You might have heard of people having late stage cancer or stage 1 cancer or grade 1 or grade 2, these sorts of things. The type of cancer is important. You know, what cell type we're dealing with, what tissue. Is it a lung cancer? If so, what type of lung cancer? Is it a breast cancer? Is it a colon cancer? If so, what type? All of this impact on the treatments available to us. And their genetics, we've mentioned that. What is it that is switched on or off in these cancer cells that we can maybe use? And what can't be underestimated, patient choice and aim. What is your aim? Our aim isn't always to get rid of the disease. The aim might be to palliate or to keep people comfortable for a longer period of time. Or the patient might decide, listen, I've had enough of this treatment, or I don't want the treatment, or I do want the treatment. So patient choice and the overall aim is a very important decision-making factors to this whole thing. But most of our patients will receive a combination of these: surgery, radiotherapy, and chemotherapy, sometimes all three. And each of them will cause problems. And we'll have a look at some of those problems in a little while. But then, as we know more about cancer, we're able to take a much more targeted approach. And that's what those biological therapies are. Do you remember those hallmarks of cancer? They're taking each of those and creating treatments to impact on those hallmarks. So it's a much more targeted approach. And we'll look at why we need that in a little while. And I don't know if you noticed that one of the hallmarks of cancer is that cancer cells are very good at evading your immune system. Actually, let's be clear, your immune system is very good at picking up cancer cells. So a strong immune system is good. Yeah, it's very good at picking up cancer cells. It gets rid of a lot of cancer cells. But obviously there are some cancer cells that it doesn't pick up on. Well, we're developing strategies now to allow the immune system to see those cancer cells again, so that then they will attack. If we understand the fact that your immune system does kill cancer cells, if it can see them, then as long as we can allow the immune system cells to see the cancer cells, they will kill them. That's how it works. Yeah. So I'll say a little bit more about that in a little while. Before we move on, I'm going to take a couple of these things and just expand on them in the next few slides. But are we okay with what we've said so far? Are you still following what I'm saying? I'm giving you sort of a cook's tour about all of these things. Give me some feedback. And don't forget, if you have any questions, feel free to type them in, or we'll do them in the question and answer session later. Are we okay so far? Good stuff. Thank you, Joanna. Excellent. There's lots of different drivers which impact on treatment and management of the cancer patient. But two of the bigger drivers is staging and grading. And I just want to put those definitions on without really giving you, we're not going to go into any great detail, but I want to give you a bit of a sense of what these things give us and why they're so important. So grade is an estimate of the degree of malignancy of a tumor. Don't forget about that word differentiation. But what grade is in effect is when we look at these cancer cells down a microscope, they are abnormal. Yeah. So what the grade is, it's a sort of it's a definition to show us. Yeah, absolutely, Christina. Absolutely, absolutely. We can't, in my opinion, at this moment in time, we can't cure our way out of this situation. But what we can do is manage it. Yeah, and we've got to accept the fact that there are going to be people coming to our door with cancer. There are people coming through our door that are in active cancer treatments. There are people coming through our door who have survived cancer but have issues around that survival caused by the treatments. We need to manage that. We need to help people through that. Absolutely, 100%. But if you hear people talking about they've got grade 1 disease or grade 4 disease, what's that basically telling us is how many cells in that cancer look fairly normal and how many of those cells look very abnormal. Now, why is that important to us? Let me just give you, there's a sheet of paper, look. It's a sheet of paper. Imagine that is a normal cell of the body. It's a normal cell. It's perfect. You can't get any better than that sheet of paper. It looks like a sheet of paper and it behaves like a sheet of paper. I could put it through my printer and everything. It's brilliant. It's a sheet of paper. It's your normal cell of your normal body. You can't get any more perfect than that. If I put a little bit of a crease in there, look, I don't know if you can see that. I'm sure you can see it. A little bit of a crease. It still looks like a sheet of paper, but it's not quite as good, is it? I can't put it through my printer now because it'll cause a jam. But I can still write on it. I can still put my to-do list and everything. Yeah. So this represents a cancer cell, but it's only slightly abnormal. Yeah. The more I scrunch that paper up, the less like a normal sheet of paper it looks. And this is what this is what helps us represent grade. The more cells that I have that look like this, the higher the grade, the worse it is. Now, let me just show you something. Watch this. I can't even throw that. Watch this. Wow, look at that. So this cell that looks very, very abnormal, it's got different characteristics. It doesn't behave like a normal cell. I can't put it through my paper or anything like that, through my printer, but it's now got other characteristics. It makes a much better missile. It's these characteristics that these cancer cells develop which allow it to spread. The link is the higher the grade, grade 3, grade 4, the greater the likelihood of metastasis, of spread. And that's why the grade is important to assess, because it gives people working in clinics an idea of whether they need to look for metastases and things like this. Yeah? That's what grade tells us. Stage is different. Stage is physically looking at maybe the size of the tumor and whether it has spread. So it looks for evidence. So the stage will tell you, oh, you've got a small tumor in the breast and it's nowhere else. Or it'll tell us that you've got a larger tumor in the breast and it's also involving the lymphatics and it's also involving other parts of the body. So that's a physical description of the anatomical extent of the tumor. So something that is high grade, high stage 3, stage 4, it means it's starting to spread around the body. The point I'm sharing, the reason I'm sharing this, because you might have people coming through your door and say, oh, I've been to the doctor, I've got stage 3 breast cancer or whatever. You need to have maybe a little bit of a sense that that means that it's started to spread around to the lymph node and things like this. So that's all that these definitions tell us. But they're important from a clinical perspective. So let's just quickly look at some of the treatments, because I'm aware of time and stuff. Not in any great sense of what the treatments are, but to give you some idea of things like the side effects of these treatments. Radiotherapy uses radiation to kill cells. But the thing about it is, it will kill healthy cells as well as it'll kill tumor cells. Now, there are things that we can do to help us kill more tumor cells than healthy cells, but we still kill healthy cells. The problem with that, of course, is that it causes side effects. Now, we know that a lot of people experiencing radiotherapy will be fatigued. Now, they're fatigued for 2 reasons. The first reason is that we are damaging a lot of cells and the body is repairing. So that uses a lot of energy. And the other reason is that we expect these people to come into radiotherapy departments every day, 5 days a week, for maybe 4 or 5 weeks. It is exhausting. Yeah. So a lot of these people experience fatigue for a long period of time, maybe even leading into things like depression and stuff like this. We know that the radiation will cause damage to tissues. It will cause hair to fall out if we've got hair within the radiation field. So you can see there, it's very demarked, isn't it? Just where the radiation's been. We don't get total hair loss with radiotherapy generally, but we do get epilation. We get hair loss in the area where the radiation is hitting the skin. What we also get is inflammation, particularly of the mucous membrane if it's involved within the radiotherapy field. So if we're treating around the head neck area, the inside of the mouth will get very, very sore indeed, because we get mucositis. We might even get things like dry mouth because we affect the salivary glands and things like this. If we're treating around the lower part of the body, we'll get nausea and maybe diarrhea and things like this. And all of these things need to be managed. We can't get anywhere inside the body without going through skin, and we damage the skin. And you get this sort of, well, we call it, the technical term is erythema, where we get this reddening of the skin. That can become very sore. But again, it's only where the radiation is. So coming back to the industry that some of you guys might be in, we've got to be very careful in abrasion in those areas there where the skin is already tender. So these sorts of things we need to be aware of. You know, if a person is having radiotherapy, where are they having the radiotherapy, and do we need to take that into account, for example? Now, in severe cases, that skin will start to break down and it will become what we call desquamation. And we just need to be very careful and mindful of that. But be mindful also that we don't just get the physicalness of the reddening of the skin, but we might also get soreness on the inside as well because of the radiotherapy. Chemotherapy is the same, except the thing with radiotherapy, it's usually directed on one part of the body, whereas chemotherapy tends to go around the whole body, and so therefore we get loads of side effects. Now, there are certain chemotherapy drugs which are toxic to particular organs. So we know that some chemotherapy drugs are cardiac toxic, some are toxic to the lungs, for example. But generally speaking, most of the chemotherapy side effects will involve a whole range of side effects across the whole body. Mucositis again, alopecia, where you get total hair loss, neuropathy sometimes because we get problems with the nerves, nausea, vomiting. Generally speaking, the side effects that we get, those generalized side effects, tend to be in tissues of the body that are quickly and rapidly dividing. Yeah, so we're making new hair like crazy. So it's the hair follicles are quickly affected by the chemotherapy. The lining of the gut, we're making new cells like mad, so they're quickly affected by chemotherapy. So you got diarrhea, feel nauseous, these sorts of things. What you might not be aware of course, is that we also know that chemotherapy can give longer term effects. Fatigue, again, very well documented that people receiving chemotherapy will be fatigued for many years after having their chemotherapy in a lot of cases. We also have chemo brain, where the chemotherapy has affected thought processes and memory and things like this. And you might come across that with some people that you come across. And what you might not be aware of is that we do know that certain chemotherapy drugs are also carcinogens, that people come back maybe with a second type of cancer caused by using those drugs. It's only a small percentage, but it's an important small percentage. So the problem with those treatments is that they cause too many problems. Radiotherapy is great, chemotherapy is great. There are certain types of cancer that we wouldn't have the success that we do without those treatments. But we can't do it without collateral damage, because they don't really look at the differences between normal and cancer cells. They just kill cells. Now we have to sort of manufacture a difference. So these more targeted approaches, looking at how that cancer, those hallmarks, really important in being able to generate a treatment which is targeting the cancer cell and not just randomly cells, and hopefully we kill cancer cells. So we've already talked about all cells rely on messages, on-off switches, but normally it's balanced. In the cancer cell, we have too many on switches and not enough off switches. we need to somehow stop that message and maybe even switch the off messages on. And that's the general sense of those targeted treatments. Okay. So those hallmarks of cancer allow us to do that. There's one other type of treatment that I just want to introduce you to because it's very important. It's very much in the press, and that's this idea of immunotherapy. Now, we talked about the immune system can see cancer cells. The T cells, T lymphocytes, are part of this process. They monitor. Yeah, they look around for cells. The T cells need to be able to recognize your own cells, otherwise they will attack. So what T cells do is they come across a normal cell, and the normal cell sticks out its hand, and the T cell shakes the hand, and we call that a checkpoint. And that's the T cell checking that the normal cell is a normal cell because it knows to give a handshake. I call it a molecular handshake. Yeah. So when that handshake is realized, that's the T cell saying to the normal cell saying to the T cell, look, I'm normal, leave me alone. Now, the thing about a virus is that it doesn't know to give the handshake, and therefore the T cell attacks. That's how the immune system works. It's a series of recognition points, basically. Now, the thing about some cancer cells, are sneaky little beggars, is that these are your cells. And the point of that is when the normal immune cell is looking around, sees a normal cell, handshake, brilliant, sees a cancer cell, and you can almost see the T cell saying, oh, this cancer cell, it doesn't look normal, it looks a bit weird. But what happens is, just before the T cell is about to attack, the cancer cell sticks its hand out. If it sticks its hand out, the T cell has no option but to shake it. So the molecular handshake has taken place. And as such, the T cell leaves the cancer cell alone. And that's how cancer cells evade the immune system. So what do we have to do? Stop the handshake. So we have special drugs now, which we call checkpoint inhibitor drugs, which stop the handshake. In effect, what they do is they tie the hands of the T cells behind its back. So the cancer cell can offer the hand, but the T cell cannot shake the hand. And therefore, it will attack. And I realize I've only got about 1 minute left and I'm going to have to go. So that's what these new immunotherapy drugs are doing. And they're very powerful, but the problem that they have is that they have the potential to unleash an immune response on normal cells as well. So we need to be aware of people having immunotherapy drugs because they can have all sorts of long-term side effects associated by that almost like autoimmune response that we can promote. And what's important is that these things can happen months, maybe years after they've had the treatment. So we need to be aware, you need to be aware perhaps of people that are maybe having these types of drugs and whether that will impact on these people in terms of their long-term health. So hopefully that's give you some sort of sense of what's going on in terms of cancer in general. Now, if I had to offer some sort of personal reflections, overridingly, education, education, education. The more we learn about this disease, no, I don't mean science, of course, scientifically is important, but as individuals, as professionals, maybe working with people with cancer, the more we learn about this, the more we unpack the disease, the more we treat it with respect, but are not fearful of it too much, then the better we can interact with it. The earlier we will go through to doctors, for example. I'll give you, I still get, there's very few of us have not been impacted on cancer. Both my parents died of cancer. My elder brother died of a brain tumor. My other elder brother has just had an operation for a very early stage laryngeal cancer. So we've all been there. We've all got those stories. But by educating ourselves, I'm able to talk to my brother about what he had and reassure him about what's happened and stuff. And education is key to that. Education is key to reducing our risk. Education is key to getting people to lead healthier lifestyles, which will reduce their risk later, help them through the process of what they're going through. Having said that, there are maybe other practical things that we can do. Screening for cancer, getting it earlier. Cervical cancer the cervical screening program has just revolutionized how we deal with cervical cancer. And we've gone from having, I was working clinically before the cervical screening program came in. I saw lots of women with very advanced cases of cervical cancer. Now it's actually really quite rare. Most of the people women are picked up with in situ, very early disease, which we can deal with because of the screening program. So go to your cervical screening programs if you're given the chance. It is very, very important. Yeah. Breast screening, again, it's been around for many years, has had a great impact on breast cancer survival. And the more newer bowel screening program, which we give to people over the age of 55 in some cases, 60 in others. So important that we do it. It is a brilliant screening program that picks up lots of bowel cancers very, very early. There is a very, very close relationship with bowel cancer and whether we get it early and get good survival, or we pick it up late and not so good. So these things are really important. Now, whether we'll get screening programs in some other ones, we'll have to wait and see. There are mobile screening units already looking at things like CT scans for people with at risk of lung cancer, for example. And treatments are on the up, aren't they? Not really good. I've mentioned them ever so slightly, but immunotherapy excites me. I've had lots of cures for cancer come through the door in the last 40 years or so. But immunotherapy excites me. I'm not suggesting it's a cure for cancer, but it's got great potential if we can manage to do it right and manage people through that process. So very aware of the time. Lots of other webinars to choose from that I do. You can get access to those or more information about them throughout my website. So if there's anything that you want to delve deeper into, oh, thank you, Michelle. There you go. Then you can do that. Okay. And of course, after this session, if there's any questions, you feel free to email me. I'm happy to share my experience with people if it's helpful for them. And yeah, Michelle's alluded to it. I was very impressed to see on Michelle's bookcase behind there. So thank you for that. I hope you found it a useful resource, and I hope other people do as well. So thank you in general. I don't know what we're going to do now, Michelle, whether we can open that up for any questions, but I'm happy to stay on board for the next 10 minutes or so if that's the case.